Hello everyone. I welcome you to the dermatology series where we are discussing conditions. Here again we discuss the diverse conditions. I will provide you timestamps so that it is easier for you to navigate. What is aplasia cutis congenita? Aplasia cutis congenita is a congenital condition where the child is born with no hair, especially in this region, exactly similar to this picture. So why does this happen? This happens because of teratogenic medications such as methimazole. So when the mother has taken methimazole during her first trimester, it results in an absence of skin on the scalp area which is visible at birth. This is particularly common in drugs such as methimazole. What is the other characteristic side effect in methimazole? Methimazole, when the mother is taking methimazole in a child, it can produce aplasia cutis congenita. But whereas in the mother, it can result in agranulocytosis or neutropenia, that is a decrease of the neutrophils, which can present as mouth ulcers. Propylthiouracil can also present with agranulocytosis or a decrease of neutrophils. What do you know about hereditary angioedema? Here if you see, the eyes are swollen and the face is also swollen. This condition is a hereditary angioedema. What is the reason? The reason is there is a deficiency of C1 esterase inhibitor. This will lead to uncontrolled complement activation and increased vascular permeability, resulting in a facial edema as shown over here. The treatment for hereditary angioedema is Danazol, which is an androgen receptor partial agonist. It will stimulate, it has an additional use also. Apart from androgen receptor partial agonist, it can also stimulate hepatic production of C1 esterase inhibitor protein. So this also resembles a sinusitis picture, but the vignette, they will be giving you exactly the necessary details to identify the image. Like this is how the vignette will sound. A 5-year-old male with a second episode of facial hand and arm edema. Patient is prescribed danazol for long-term management, thereby hinting towards hereditary angioedema. What do you know about senile purpura? As the word name says, senile. In old age, there is age-related dermal changes that leading to increased fragility of dermal collagen as well as blood vessels. So when the dermal collagen as well as blood vessels have increased fragility, it will result in a purpura like this. So how do you identify it? The vignette will be 79-year-old male with a purpura on forearms and dorsal hands. Normal blood count and coagulation studies rule out systemic causes. So the only one that we are left out is the age and the purpura, and being obvious, it is a senile purpura. This is a benign condition, a normal age-related changes, and this is not going to get transformed to malignancy. What do you know by solar elastosis? Solar elastosis. What does the word solar mean? The word solar means the one of the causes sun. The sun is one of the reason for this condition. What does the word elastosis mean? Elastosis means there is thickening or wrinkling of the skin because of the sun. So because of solar is sun, but in particular the UV light exposure will lead to degradation of the dermal elastic fibers and the accumulation of abnormal elastototic material. So this will result in a characteristic leathery yellow appearance of chronically sun damaged skin. So this is known as solar elastosis. This solar elastosis has an increased risk for skin malignancies, including basal cell carcinoma and squamous cell carcinoma. I will tell you in detail about the carcinomas. Find the diagnosis. This is a histopathy picture which can be given and asked us to find the diagnosis. Here if you see, there is thickened and curled fibers in the dermis. This is characteristic of solar elastosis. What about the sun protection strategies? This is one of the high yield NBME concepts. The first and foremost protection strategy is a physical barrier, that is protective clothing worn throughout with the consistent coverage. What about the sunscreen? The sunscreen with the SPF higher numbers are also recommended, but they are not the first line because the sunscreen might have been washed away. The sunscreen would have been washed away with the sweat or with anything for that matter, and we may not be aware about the sunscreen being covering us properly or not. But physical barrier is much more easier to maintain, and it has a even more wider protection when compared to sunscreen. So the first sun protection strategy is physical barrier. The second one are the sunscreens. What do you know about PUPP? PUPP stands for Pruritic, Urticarial, Papules and Plaque of Pregnancy. Now, as the name says, what is pruritic? Pruritic is itching. What is urticarial? Urticarial is when we itch, there is elevation or a raised border is seen, so that is urticarial. And papules and plaques of pregnancy, this is a condition. Here, how will they present? They will be having a pruritic urticarial. So here there will be a papules and plaques which are oriented towards the stretch marks. This is how the PUPP will present. They will be having intensely itchy, as the name says, and urticarial. That's how it looks. Erythematous, violaceous rash on the abdomen occurring in the stretch marks. Why should that occur? It is sporadic and it can be multifactorial in etiology. So what is the key feature? It is that it involves the stretch marks. What is the treatment? Second generation antihistamines are the treatment. What about the gestational pemphigoid? Here if you see, there is a blister around it. Gestational pemphigoid was originally known as Herpes Gestationalis. This is because it almost looked similar to herpes. So they, in older days, they mistakenly named it as a Herpes Gestationalis, but the correct term is gestational pemphigoid. What happens? It occurs in the third trimester with intense pruritic rash around the umbilicus. As you see, this is around the umbilicus, but this is not oriented to any stretch marks. We can distinguish it from PUPP because this is not stretch mark oriented. So what it is? This is because the antibody is directed towards the basal suprabasal, that is the hemidesmosomes which attach the basal layer with the basement membrane. So when the antibodies are directed towards hemidesmosomes, therefore the skin looks like this, the blistering happens. So what is the treatment? Since this is an autoimmune reaction, that is the body's own antibody directed towards the body's own hemidesmosomes, the treatment is steroids. Either oral or topical corticosteroids can be given. What do you know about intrahepatic cholestasis of pregnancy? This is quite a fatal condition. Here there is what it is. There is deficiency of the enzyme LCHAD, that is long chain acyl hydroxy dehydrogenase. Why do we need this? This is necessary for the proper drainage of the production and drainage of the bile acids. So since the proper drainage and production doesn't happen, the bile acids are elevated. The elevated bile acids can cross the placenta and it can even enter the fetus. So what does the elevated bile acids do in the mother? Initially it can result in a nausea and vomiting. This presents in the third trimester. So when a mother in the third trimester complains of nausea and vomiting, it should not be taken lightly. Care has to be given. Following, itching will happen because of the elevated bile acids, and then it can progress to jaundice. Ursodeoxycholic acid or ursodiol is the treatment if we had identified or diagnosed in the early stages, because it reduces the maternal symptoms and may improve the fetal outcomes too. But if it has been left to proceed or progress, then medical termination of pregnancy is the treatment. Otherwise, it can result in spontaneous abortion. But the third trimester abortion is not spontaneous. It's not called a spontaneous abortion. It can result in stillbirth. I have a video which is explaining the dermatological conditions separately. I will give you the link in the description. What about idiopathic thrombocytopenic purpura? Here the key concept about it is idiopathic, or I also stands for immune. So we can either call it as idiopathic or immune thrombocytopenic purpura. Therefore, This is because of the antibodies, that is immune, right, against GP2B3A receptors. In the platelets, we have two set of receptors. One is GP1B9, which is responsible for adhesion. The other receptors are GP2B3A, which is responsible for aggregation. So when the receptors against GP2B3A occurs, then aggregation doesn't happen, and therefore platelet dysfunction like nosebleed, hepatical rash, all happens. In here the vignette will give like a 12-year-old male with a weak history of nosebleeds and petechial rash. Laboratory, so this hints towards some bleeding disorder. Laboratory findings reveal prolonged bleeding time of 9 minutes and platelet count of 90,000. So platelet count is also reduced and a bleeding time is also increased. All these directs towards a platelet disorder, and that is the idiopathic thrombocytopenic purpura. How do you diagnose this? How do you confirm the diagnosis? Decreased platelet count is the diagnosis for it. What is the treatment? Corticosteroids, because this is an autoimmune reaction and the antibodies are directed towards GP2B3A, right? So therefore corticosteroids are the first line treatment. The second line is the intravenous immunoglobulins. In very extremely refractory cases, splenectomy can be done. What do you know about basal cell carcinoma? In basal cell carcinoma, what it is, from where does it arise? The basal cell carcinoma, as the name says, it arises from the basal cells. What are the basal cells? We have 5 layers of cells. The basal most is the stratum basal. So basal cell carcinoma is the one which arises from the basal cells. So how will the basal cells be? The basal cells will have increased nucleus or cytoplasmic ratio. Therefore, they will be basophilic. This is the first one. In addition, they will be proliferating such that they will have a translucent mucous membrane around it. So this is the second point. Now, if you see here, the basal cell carcinoma will be pearly translucent. That is the key feature for basal cell carcinoma, and along with it, it will be proliferating towards the along the periphery. Therefore, there will be rolled up heaped edges. Any carcinoma will have angiogenesis. Therefore, there will be blood vessels will also be obvious. What about the center? The center can ulcerate. It may or may not ulcerate, and it can cavitate, resulting in a cavity kind of. So these are the key features of basal cell carcinoma because of the characteristics from the cell that it originates. Here this picture can be given, and you need to find out that it is basal cell carcinoma by the presence of pearlescent appearance, translucent appearance, heaped up borders, and telangiectasias. How will the vignette be? 67-year-old male with nasal lesion showing characteristic morphological features of basal cell carcinoma. So this is how. And they can ask you the treatment. Most micrographic surgery is recommended for cosmetically sensitive areas. Why? This is because in cosmetically sensitive areas we can't remove a large amount of skin. Therefore, in most micrographic surgery, micrographically we will be excising the borders, looking for neoplastic cells, and if it is negative, then we leave out. But if it is positive, then we remove a small minute border too. So the basophilic staining. So this is how it will be because of the increased nuclear cytoplasmic ratio, and with increased chromatin disaggregation within the nuclei, they will be basophilic. The treatment is most micrographic surgery, that is a layer by layer they will be removing. Once they find the complete clearance, they will stop the treatment. There is also another treatment apart from surgery. It is a topical immunomodulator therapy, which is the medication is known as imiquimod, which works by stimulating the toll-like receptor TLR7, thereby enhances the immune response. But if you ask me if this can be given, that this is a lotion kind of topical. Imiquimod is topical. If you ask me if this can be given, then why should we go for most micrographic surgery? You are right. We cannot do this for everyone. This can be done only when the lesion is less than 2 cm, if it is not nodular, and if it is not infiltrative. If it is widespread and if it is profuse, in that case the surgery is the treatment. What do you know about actinic keratosis? If you look at this picture closely, this is the picture for actinic keratosis. Actinic is, if it can be translated as UV light exposure. This shows that because of increased UV light exposure, there is papules and plaques on the skin. This is pre-malignant. They can progress to squamous cell carcinoma. Therefore, cryotherapy should be done for the lesions so as to prevent the progression to cancer. Actinic is a term which can be translated to sun exposure or UV light in particular. As I told you, it can get progressed to squamous cell carcinoma. So how do you differentiate squamous cell carcinoma and basal cell carcinoma? When there is absence of telangiectasias or pearlescent or translucent appearance, it is squamous cell carcinoma. But it can happen, it can have rolled over edges, and ulceration can happen in squamous cell carcinoma. In basal cell carcinoma also, you can have a rolled over edges as well as ulceration. But the characteristic telangiectasia and pearly or translucent appearance is the feature for basal cell carcinoma. What is this? So this is the comparative feature where it shows squamous cell carcinoma on one side and actinic keratosis on the other side. What about the histological features in squamous cell carcinoma? So you should know from where the squamous cell arises from, carcinoma arises from. Squamous cell carcinoma arises from keratinocytes. What are keratinocytes? Keratinocyte is that layer which is the topmost layer of the epidermis. So it is not only the topmost layer, the keratinocytes are those which are produced from the basal layer, and as it progresses, it is present at varying levels of differentiation. At the third layer, that is in the stratum spinosum, it is beginning to produce a keratin and becoming to form more mature keratinocytes. At the final layer, that is the topmost layer, stratum corneum, it will form a full-blown keratinocyte, and it is present on the topmost layer, giving protection for the skin. Fine. So this is about the keratinocytes. The second point is that the keratinocytes are the one which will be producing keratin, obviously. The third important one is that the keratinocytes are, that is in the topmost layer, they are present, the adjacent keratinocytes are attached to each other with desmosomes. So now how will the squamous cell carcinoma be? These are the intracellular keratin, because they arise from the keratinocytes which are known to produce keratin. And the second one is they will be produced, they are attached with each other by desmosomes. So therefore we have intercellular bridges which are nothing but the desmosomes production. So this is in short about squamous cell carcinoma. With this, we have come to the end. I would like to add 2 more points. Smoking and immunodeficiency are the predisposing factor for squamous cell carcinoma. So with this, we have come to the end of the lecture. I am happy that you have traveled with me this far. If you like my videos and if you want me to mentor you, I'm a medical doctor. I'm an anesthesiologist with a passion for teaching. If you are a medical graduate student, or if you are preparing for any special exams like MLE exams, then and if you want me to mentor you, I'm more than happy to welcome you and guide you. So looking forward to see you succeed. All the best for your exams.